Welcome everyone to today's program. I am Ayla Ellison with Becker's Healthcare. The program will begin with a presentation and will be followed by a question and answer session if time permits. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program, and you can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to introduce today's moderator, Andrea Ferrari. She is a director with Healthcare Appraisers and works out of the company's corporate headquarters in Delray Beach, Florida. She brings to Healthcare Appraisers her nearly 20 years of experience in the healthcare industry and works with clients in nearly all 50 states. Ms. Ferrari joined Healthcare Appraisers from the Health Law Practice Group of a large international law firm. She has experience providing counsel and representation to various types of clients in the healthcare industry, including hospitals and health systems, physicians and physician groups, and pharmaceutical and medical device vendors, distributors, and manufacturers. Ms. Ferrari has previously worked as Associate General Counsel of a public health system and in the in-house legal department of a major academic medical center. Prior to becoming an attorney, Ms. Ferrari coordinated clinical trials in healthcare quality and patient safety research for more than 7 years. It is now my pleasure to turn the floor over to Andrea to begin today's presentation.
Thank you, Ayla. Good afternoon, everyone. As Ayla mentioned, I'm Andrea Ferrari, and I'm going to be the moderator for today's webinar program. We have what I think is a great panel and some interesting topics to cover, culminating in our 7 tips for hospitals, which will be helpful, I think, as they enter 2016 and the next evolution of Post-Affordable Care Act healthcare. I have the pleasure of introducing our panel. One thing you may note about the panel is that although it's composed of individuals who work in various advisory roles and have various experience, for which I'll give you a flavor in a minute, all have been trained as lawyers. I think this is fitting for the focus of the program, since the developments of 2015 and the look ahead to 2016 are really heavily influenced by regulatory and legal developments. And so understanding them requires some understanding of the current legal and regulatory issues in the news. And who better to help provide such understanding than a panel of lawyers? On the other hand, we all understand the fear that when all together on the same platform, lawyers might revert to their preferred language of legalese and make some folks, even other lawyers, ready for a snooze. So we're not going to do that. We have a dense slide deck with lots of information for reference, but we're going to move through it quickly and let you all decide whether you want to review it later at your leisure or use it as a cheap doorstop. In addition to our panelists, we have a special guest today whose name doesn't appear on the slide, and that's my colleague, Jamie McIntyre. I'm very happy to have Jamie join me on this panel to talk a bit about the interesting trends in hospital co-management arrangements. Co-management is a hot topic yet again in 2015, and it most likely will be for 2015 and beyond. So a little more about our panelists. Adria Warren is a partner and healthcare transactional attorney with Foley & Lardner, LLP, which is a national law firm providing comprehensive legal services for the healthcare, pharmaceutical, biotechnology, and biomedical sectors. Adria's practice focuses on advising clients on healthcare corporate and regulatory matters, including mergers, acquisitions, affiliations, financing, transactions, and business operations. We have Kelly Anderson, who's Associate General Counsel for Baptist Healthcare System in Kentucky, which includes 7 hospitals, a physician network, and a variety of other healthcare provider entities. She provides legal advice regarding all aspects of the system's healthcare operations, including business transactions, regulatory issues, risk management, employment, compliance, and contracting. Vivian Gallo is a Florida Bar Board Certified Healthcare Attorney who recently joined Halifax Health as its Senior Vice President and General Counsel, and she is responsible for overseeing physician contracting and all legal matters for this public hospital system. Prior to her role at Halifax, Vivian served as in-house counsel for UF Health Shands, Miami Children's Hospital, Nemours, and the University of Pennsylvania Health System. So a lot of experience there. And finally, we have Robin Revelson, who is in-house counsel for Kettering Health Network, a hospital system composed of 7 hospitals, a physician network, and 3 freestanding emergency departments in Ohio. In her role, she serves as the key contact for physician contracting and fair market value and commercial reasonableness. My colleague Jamie McIntyre, as I mentioned, is also joining our panel. She is a manager here in the Delray office of healthcare appraisers, and she specializes in fair market value analyses for compensation arrangements, which may have Stark or anti-kickback implications. Specifically, she and her team focus on the valuation of management and co-management arrangements. Prior to joining healthcare appraisers, Jamie worked as a contract administrator at a tertiary care hospital. Next slide, please. Being lawyers by training, we have a few disclaimers to make about the program before we get started. First, this program is a general discussion of legal and business issues. It should not be relied upon as legal evaluation, business, financial, or other professional advice. Second, the speakers will present their own views and not those of their current or past employers or clients. Third, not all the slides will be covered in detail. We have a pretty dense slide deck. Some of the slides here are for your reference only. Fourth, the slides are the result of collaboration of your panelists, and they reflect their individual and collective thoughts and observations. We don't agree on everything, but we certainly have interesting thoughts and respect each other's opinions. This presentation might include discussion of hypothetical scenarios. These hypothetical scenarios have been devised to be realistic and to elicit thoughtful and lively discussion, but they don't represent actual events. And then finally, the presentation includes a discussion of certain ongoing and settled qui tam lawsuits. This discussion is based on publicly available documents regarding the allegations in the lawsuits. And we want to remind the participants that allegations are just that, allegations only. We also wish to remind you that participants are going to discuss a selected list of cases, and that's not necessarily a comprehensive list. Next slide, please. The general agenda for today's program is as follows. One, we're going to provide context for much of what we're going to discuss through a very brief overview of the importance of fair market value and commercial reasonableness to healthcare transactions. Next, we will review the 2015 hospital transaction trends as we see them, focusing on what we have each seen as hot topics and trouble spots in 2015 and what we've learned in 2015. Third, we'll provide some insight and analysis of the factors contributing to the 2015 transaction trends, as well as what those factors might mean for the look ahead to 2016. Fourth, we'll have a little bit of an extra primer on the regulatory environment for hospitals and how it's changing. We have to get some of that legal stuff in the program. And then finally, but definitely not the least of our emphasis, in fact, this is probably the biggest portion of our program, we'll have our 7 tips for hospitals to plan for 2016 and beyond. Next slide, please. So this slide contains a lot of information that is intended to give an overview of the various laws and regulations that make fair market value and commercial reasonableness focus areas, and to some degree drivers of hospital transactions. We're not going to spend any time discussing the content of the slide, but just want to point out that it's here for your reference and context as we discuss the developments of 2015 and the look ahead. The same is true for the content of the next slide, slide 6 of this presentation. It's meant for a reference point only. Can we advance to slide 7, please? The backdrop for many of the hospital transactions on which we work and on which we think about at night are 3 primary, or if not primary, at least important prongs of regulatory enforcement. 3 questions. Is the transaction fair market value? Is it commercially reasonable? Is the compensation based on volume or value of referrals? I'm now going to turn things over to Robin to talk a little bit more about how and why these 3 considerations are and probably will continue to be important before we get to the transaction trends of 2015. Robin?
Next slide, please. Above are the main factors for fair market value and commercial reasonableness and reasonable compensation under the IHS. As you'll see, the main question to be asking is, would this deal be made without taking into account the volume or values of referrals? As you'll see when my fellow panelists discuss some of the recent settlements, the OIG is focusing their efforts on demonstrating fair market value and commercial reasonableness in relationships for hospitals and health systems and their contracts with physicians. The Stark regulations note that the compensation can't be influenced by the actual or anticipated volume or value of referrals. In other words, the amount paid to the doctor can't compensate the physicians for his ability to admit or refer patients to the hospital. Under anti-kickback, the arrangement must be consistent with fair market value in an arm's length transaction and not be determined in a manner that takes into account the volume or value of referrals or the business that will be generated between the parties for which a payment may be made by a federal health care program. There's no definitive formula to tell us when compensation is or is not reasonable or when it represents fair market value. So determination of commercial reasonableness in fair market value depends on all of the relevant facts and circumstances. Reasonable compensation is generally defined as the level of compensation that is consistent with the amount that would be paid by like organizations for the like services under the circumstances. I would recommend as a first tool when examining these to look at the fair market value as compensation surveys to determine if the compensation falls within the typical range for the specialty. It's also important to look at different things like production, practice projections in comparison to prior compensation for physicians. It's important to be able to demonstrate that the transaction is not an excess benefit to the physician when looking at the importance of fair market value and commercial reasonableness. And I can now turn it back over to Andrea for the next slide.
Okay, so Robin's comments, I think, are going to be background to keep in your head as we kind of talk about the developments of the last year and what we foresee going forward because there's a lot of regulatory enforcement activity. We have, in the next section of this presentation, three categories of transaction trends that we've identified and some observations about each. Those are consolidation, clinical integration and alignment, and new or newer compensation models. And I'm going to turn things over to Adria to talk a little bit about consolidation trends among hospitals.
Sure, thank you, Andrea. Can we have slide 11, please? In 2015, there was a large increasing number of transactions. In particular, their healthcare sector mergers had been at record highs in 2014, and movement in numbers of employed physicians in 2013 and 2014. The final 2015 statistics are not yet available, but there was a great deal of transaction volume and physician employment, as I just said. And also a lot of movement towards affiliations and joint ventures and partnerships. So we'll talk a little bit about what those deals were with a kind of a question mark at the end about 2016. Next slide, please. The first and what I consider a pretty basic transaction structure, as I mentioned, there was increase in physician employment and acquisitions by hospital systems of physician practices and groups, either through asset purchase or stock purchase, is generally a way of aligning with physicians. This diagram shows a fairly common transaction structure where the assets are purchased and physicians and staff are subsequently employed from the pre-existing practice. This model allows the system to segregate off liabilities, so it has some good advantages. It aligns the physicians and the systems. Once you have employed the physician, you have a less legal risk involved. You can engage in joint pricing without violating antitrust concerns. You can refer and share ancillaries without fraud and abuse law, legal compliance issues. And you can hire and grow for competitive purposes through these models. Next slide. And the next one also is a stock purchase transaction. This may be seen a little bit less frequently. This allows the system to employ directly also where it can employ without violating any state restrictions on corporate practice of medicine, if there are any, without going into detail on that. But also, one of the advantages of a stock purchase is the physician practice is acquired in its entirety. So the legal entity is acquired, and its taxpayer ID and provider numbers stay intact, which is sometimes advantageous depending on the type of deal. But the acquirer does take on all the liabilities, and due diligence really becomes key in all sorts of transactions, but in the stock purchase in particular, there's a real onus on conducting sufficient due diligence. Next slide. A great deal of my work and a great volume of activity over the last year, 2015, was in the form of a lot more of alignment transactions, and PSA or PSA Plus arrangements were really highly used. These are professional service agreements and arrangements, and it provides an alternative model for integration that will allow a physician group to staff an existing site or a service line or develop a new facility, and the parties, the system and the physicians, would work together to improve quality, efficiency, operations. So in this model, as you see in this diagram, the hospital may establish a practice site, which may be the physician's pre-existing office site, and they would pay the physician group fair market value comp on a fixed fee or an aggregate RVU basis. The group then pays its own employees and physicians. And there's numerous things going on here. There are stark prohibitions under arrangements where the physicians cannot have an investment interest in the entity that performs the services, and so as we are showing in this model, the hospital system is acquiring the assets and the leasehold interest in the physician office, and then engaging the physician practice through a PSA. And those various levels of the transaction would all need to meet the various exceptions and be tested for regulatory compliance along the lines of what my colleagues were talking about earlier on the call. And another thing is that these transactions can be structured if the clinic site meets provider-based rules, then reimbursement, at least in 2015, could be available for these locations, and still in some capacity, we'll talk about that. There's some recent regulatory changes that could affect the economics of a transaction. Can I have the next slide, please? So in 2015, these are some of the issues that were faced in the transactions and potential deal breakers. As I mentioned, the importance of due diligence, not just legal and business risk, but also cultural fit is very important. Some of the big dollar value items here, EHR, IT, and also going to cultural fit, governance, and decision making, and in particular in the PSA model, there's the availability for the physician group to maintain their autonomy, and we would typically have a joint operating committee or some way of having the parties work together. But what's in store for 2016? And later in this webinar, we're going to get into some of the recent legal changes that could have impact on the ability to convert space to qualify for provider-based rates, and also the 340B drug pricing opportunity. So there are other models that are becoming available. Next slide, please. And in particular, some of the alternatives are network models, contractual affiliations, clinical affiliations, branding arrangements, joint ventures, management services. This particular one here is an illustration of a clinical integration network, which the FTC defines as an active and ongoing program to evaluate and modify practice patterns by network physician participants. And it really creates a high degree of interdependence and cooperation among physicians who are not necessarily employed, a diverse group of physicians who will cooperate to control costs and ensure quality. So the goal is really to achieve the triple aim of healthcare, which is the improved experience of care and lower per capita costs and increased health. And ACOs, PHOs, IPAs, probably everybody's heard of those. Those are all types of clinical integration networks. One area of concern here in particular is antitrust risk. There's prohibitions on restraining trade and commerce, and achieving a high degree of clinical integration with that interdependence and cooperation, like I mentioned, is really central to being able to operate as a clinical integration network. And in particular, if financial integration, the second prong of financial integration, is achieved, then joint contracting may be permissible from an antitrust FTC standpoint. If it is basically, it would need to be reasonably necessary to achieve the efficiencies and the integration goals. So really kind of coming together on an integrated basis, investing in infrastructure, devoting time, clinical protocols, really working to improve efficiency and quality, and if joint contracting is something that would help advance those steps and the goals of the clinical integration network, then that may be available from an antitrust perspective. Next slide, and I'll hand this over now to Andrea.
Thank you, Adria. Back on slide 11, we had some statistics about healthcare trends starting in 2013, and we pointed out that between 2013 and 2014, there seemed to be a massive increase in the number of physicians who were being employed, a lot of practice purchase acquisition transactions. And that seemed to be continuing into early 2015, but also that there was some data indicating that in 2015 there's also been a shift away from mergers and acquisitions toward more affiliations, joint ventures, partnerships, particularly among hospitals. And I think that there are various reasons for that. One relates to the fact that there is this ongoing emphasis of quality and value in a lot of what the government is doing, a lot of what is happening in the marketplace, and the ways to achieve quality and value typically provide or require collaboration and coordination among providers. I mean, it's largely considered essential, and you can't acquire all the providers. I mean, from an antitrust perspective, from a business perspective, that's not necessarily a viable thing. And so there's always this the quest to kind of find ways to get everybody on the same page, providers who are going to remain independent but still need to be working toward a common goal. And the clinically integrated network seems to be one method that an increasing number of hospital systems are embarking on or attempting to sponsor in order to help achieve those quality value coordination goals. Some of the issues that have come up with the clinically integrated networks in the past year include questions related to whether it's okay for the hospital-funded entity to lose money if the network is a hospital-funded entity. Is it okay for it to lose money in its initial years? It's an interesting question, particularly given the discussion of losses that is primary among regulatory experts in healthcare right now because of some of the recent lawsuits, particularly qui tam lawsuits that we will discuss a little later in this presentation. Some of the questions that we often get on the valuation side are whether there is value that's a little bit different based on whether we're talking about a not-for-profit or for-profit entity. How does the network manage its analytics? There's a huge investment that's typically required into IT and electronic health records in order to be able to yield the analytics that are necessary for the clinical integration. And then once you have that information, and this is more of a legal question, what do you do with that information? How do you create provider accountability? And it's often done through financial incentives. And so the question is, what is the fair market value of those financial incentives? So we just have here on this slide a list of questions that are hot button questions in 2015. I don't know that any have answers that are set in stone or right or wrong, but things to think about as we go through the presentation. Next slide, please. One of the other things that we're seeing a trend toward is gain sharing. And one of the reasons that gain sharing is perhaps garnering new interest has to do with the legal and regulatory developments of 2015. There's been this question, is gain sharing legal? We know that in 1999 there was an OIG Special Advisory Bulletin that warned that gain sharing might violate the civil monetary penalties law. But then from like 2001 to 2012, there were 16 OIG advisory opinions that approved specific gain sharing arrangements. Each of those arrangements had very specific safeguards. And so there was an idea, well, maybe gain sharing could be okay. Okay, I'm sorry, I have a little frog in my throat, so I'm going to take a break here. There was a thought that gain sharing would be okay. You know, I'm going to actually ask one of my other presenters to kind of step in for a minute. Adria, do you want to maybe talk a little bit about this since it's in your wheelhouse?
Sure. Yeah. No. So there has been evolution on gain sharing a little bit, with there being tension between allowing physicians to participate in reduced savings and the fraud and abuse concerns. So what we have here is the kind of the continuum and the evolution of the thinking about gain sharing, and most recently in 2015, there was a modification of the civil monetary penalty law around gain sharing to reduce restrictions on it, and with the question being whether gain sharing would be permissible, or whether there be what the risk was of fraud and abuse in connection with these sorts of payments, and in particular if it was if it's not medically necessary. There's starting to be a recognition that there may be ways to compensate. Next slide. Andrea, I hope that captured what you were going to say. So I'll go on. So gain sharing arrangements, there are still some that there are obviously garnering new interest, and there are still questions around them. And in particular, we've highlighted here some of the concerns, the fraud and abuse around the fair market value. There's no specific Stark Law exception, as we mentioned. And then we've highlighted some of the questions that we're starting to see on the valuation side and also on the transaction structuring side. But really there is a lot of momentum moving towards these sorts of transactions among the changing payer models. And as these new innovative models are starting to take place, and I think it might be easiest to talk about in the context of some of these arrangements. And so if we'll turn to the next slide, we were going to think about how these sorts of incentives can be addressed in the context of co-management in particular. And I think, Jamie, did you want to step in and start talking about some of the co-management structures?
Sure. Yes, that's perfect. Thank you. So, although I think the firm that I am currently with is in a fairly unique position with respect to co-management, we've had an opportunity to value, I think it's now north of 1,000 of these deals. And we like to say that if you've seen one, you've seen one. I will talk about a couple of trends that we've seen in 2015 specific to co-management. As a note, I'm going to refer to the structure generally as co-management interchangeably, even though there's a distinction between the JV co-structure and a true management structure, which I think Adria is going to talk a little bit more about later. So first and foremost, there's been a fairly prevalent trend in 2015. We've seen several new iterations of co-management. Many times, clients have asked us to work on valuations where a single co-management arrangement at a single hospital for a single service line is now evolving into a multi-service line, a multi-hospital, even a multi-regional deal. As the co-management vehicle reaps successful alignment between physicians and the hospitals where they work, these arrangements are now entering into third or fourth or fifth years, and sometimes even beyond. And where that occurs, sometimes as these arrangements mature, the hospitals are moving toward a multidisciplinary or even a multi-service line model, wherein there's a trend away from the typical service line specific goals, and now toward a collaborative hospital-wide sort of goal. For example, where there used to be a service line management or co-management arrangement for orthopedics and specific to orthopedics, and a separate service line arrangement for surgical services and a third arrangement for cardiovascular services with relevant incentives baked into each deal. Now the hospital or the system may move to a whole hospital or a system-wide deal with incentives that cut across all of the different disciplines, incorporate all of what used to be 3 separate arrangements, and really require a great deal of cooperation and collaboration across the entire continuum of care. So something very different than we've seen in the past, requires a lot of cross-disciplinary effort. Likewise, we're seeing an increase in the number of multi-region deals. There may be several existing co-management arrangements across several hospitals within a given system, and toward the end of implementing system-wide goals or achieving what now are system-wide standards and expectations, the systems are calling upon the physicians involved in those different regions and those different previously existing arrangements, and now consolidating the arrangement into what we would call an HQEP, a hospital quality and efficiency program, or an HEIP, a hospital efficiency improvement program. We have had an opportunity to value several of those as well. Another issue that's come up a lot this year, and mostly in the past several months, there's a concern over the changing regulatory landscape with respect specifically to medical directorships. Unlike in the past, this year we've now seen actions involving individual specific medical directors for issues of impermissible compensation arrangements. Probably for that reason, we're getting many more FMV requests to look at issues of stacking, specifically in the context of medical directorships, PSAs with an element of administrative services, co-managements with named medical directors. Sometimes these arrangements are administered alongside and sometimes even coterminous with one another. So 2 critical points on this. First, it's always important to remember that even if each of those individual pieces, the medical directorship, the PSA, the co-management, is individually consistent with an opinion of fair market value, that doesn't necessarily mean that the entire arrangement taken together is still consistent with FMV. That's a question that we get a lot. Just as importantly, you always want to be careful that there are not any overlapping or redundant duties such that you would end up in a situation that the hospital has paid duplicative payments for the same or substantially similar services. A third trend that we have seen lately is the proliferation of gain sharing endeavors for obvious reasons. The posing of a potential for co-management physicians to either become involved in separate gain share arrangements with payments administered completely separate from the co-management payments, or for gain sharing type endeavors to be incorporated and baked into the renewal of a co-management arrangement. And I think that's something we'll talk about a little bit later as well. Finally, we're seeing a lot of requests to review the implications or the potential implications of bundled payment arrangements on existing or proposed co-management arrangements. So this may be, voluntary through BPCI or mandated through the CCJR program. Since specialties like orthopedics are really popular for service line co-management, and traditionally hospitals that had very robust, for example, joint replacement programs would enter into co-management arrangements. It was just a really popular structure. Obviously, bundled payment and CCJR programs are going to have potentially an enormous impact on not just the structure, but also the value of those arrangements. And generally, and I think as a last thought, as we move into a situation where we could see even more proliferation of BPCI and CCJR implications in 2016, from the seat of an evaluator, I think our primary concerns are going to be what are the arrangements that are in place? What arrangements will go into place? How are those arrangements going to be administered? Are they or are they not compensated? You know, we'll be thinking about things like what is the population that's implicated, Medicare, commercial payers, you know, what is the service line payer mix? Specifically, what is compensation being made for? And, you know, the way that these arrangements are valued and the way that valuations are being normalized is going to depend on a lot of these factors. So as a last thought, the details are important, and the structures that are deployed are going to be ever-changing and very, very important as we move forward. So with that, I'll let Adria walk through the pictorials on the structures and how those are different.
Yeah, thank you, Jamie. Next slide. And I won't spend a lot of time on this. I think Jamie did a great overview of where these arrangements are today. This is a fairly traditional co-management arrangement, just so you can see what we're talking about here. And it's really allowing the hospital to bring in the physician or physician group or groups to manage service line and reward those physicians for their efforts in developing and improving the quality and efficiency of that service line. There would typically be 2 levels of payment, maybe a fixed annual base fee and then a bonus based on a predetermined amount of bonus based on achievement of specified mutually agreed goals that you establish up front, or subject to the legal constraints that we've been discussing. Next slide. And this is a similar sort of co-management arrangement with a joint venture, a management company being established between the hospital and the physician groups. But similarly, in both models, the sorts of co-management services that might be provided would include things like both developing the service line, medical directorship, as Jamie mentioned, assisting with budget, strategic business planning, clinical protocol pathway development, community relations, assessing workflow and staffing. So really, there needs to be a real commitment of the physicians, and it needs to be that the services would need to be evaluated kind of separately and in entirety with the various levels if this model were to be combined with a PSA or other sorts of arrangements, so there's no duplicity and that you do meet the fair market value concerns. So that's the examples of some of the 2015 trends. Next slide. So, and I think is Andrea back?
I am back, and I think my voice is back as well, although I'm not 100% sure. And I apologize, everyone, for the difficulties I'm having. I had some family visiting for the Thanksgiving holiday, and one of the things that they left for me as a gift was a bad winter cold. So I apologize. So one of the other trends that we are seeing is more emphasis on affiliation, and I'm going to maybe ask Vivian to give some remarks about this in a minute. Affiliations and partnerships can be means to increase capacity and meet demand for new and expanded services, which is something that's pretty important in the post-Affordable Care Act world. It can also be a way to prepare for things like bundled payments going into 2016, during which there'll be some mandatory bundled payment participation for certain hospitals and certain locations, and we'll talk about that shortly in a minute. It's an alternative to acquisition and consolidation, and can be a means to improve quality and value of care delivery. Some of the affiliations that we are seeing a rise in academic institution affiliations with community hospitals, research institute affiliations among hospitals, and larger entities that provide research-focused services, and health system post-acute care provider affiliations. Some of these affiliations are joint ventures, others are professional services agreements, and from a valuation perspective, we're always looking to identify what the services are that are being provided through the affiliation arrangement. If there's money flowing between the parties, what is that money for? What is it compensation for? In some cases, it's for teaching services. In some cases, it's for research services. In some cases, it's for staffing a particular program or service line, or providing management services for a program or service line. There are various reasons that parties enter these arrangements, various service needs that they have, and we'll take those into consideration when we're looking at the value. I'm going to have Vivian kind of give some remarks about affiliation agreements and why she thinks, or what her thoughts are on maybe this trend and why it's come to the forefront now in 2015.
Sure. Thanks, Andrea. I think that the emphasis on affiliation is really driven by the changing reimbursement models, where quality is not just the thing that you want to have to differentiate yourselves, but now the CFOs and all the boards are looking at it because it is so tied to quality. So instead of just trying to have affiliations that might give you staffing or expand your services as say a community hospital, now we're seeing trends that community hospitals are reaching out for academic and research affiliations with those types of institutions in order to ensure that even the community hospitals have access to this cutting-edge research and evidence-based protocols so that they can be ready for bundled payments and paying for value. So it is a difficult valuation because, again, it's not just necessarily for teaching or some of the traditional services that you see. It's really so that every hospital, not just the large, huge systems, can be tracking your quality and making sure you're doing the right thing so that you're going to make sure you get paid when we all become at risk or more at risk for these payments. The other thing that we're seeing are even community hospitals are looking not just to expand their services, but we're looking at agreements for pre-hospital and post-hospital, again, in order to get ready for being at risk or, outcome-based payments, as we've seen all of these models. You want to make sure that you have the urgent cares or the primary cares lined up, not just for revenue or for business reasons, but to make sure you have an alignment if and when we all need to go into some of the, like the mandatory joint replacement bundle payment initiatives that they're trying to work out now. The community hospitals are trying to get ahead of the game at this point and make those affiliations, which does make it a little bit difficult to value because you're really just developing the relationships and making sure that you're ready when we all become more at risk. And I'll turn it back over to Andrea or anybody else.
Thanks, Vivian. Next slide, please. So in category 3 of our trends, we have newer compensation models. And what we have listed on this slide are some arrangements that have been around a long time, and you probably all listeners have some variation of these arrangements in their hospitals: employment, professional services arrangements, medical director services, call coverage agreements. Increasingly, there is some telehealth need or an attempt to kind of get into the telehealth space to expand services. And we're also seeing increasing, I guess this is maybe the newer arrangement, international service expansions and transactions. But while all of these service type arrangements have been around for some time, I think there have been some new trends emerging in the last year or two, largely related in some cases to performance incentives, particularly with respect to employment and PSAs, ways to incorporate the priorities of quality and value into the compensation arrangement. And as Jamie mentioned, because there's often a multi-pronged approach to to ensuring quality and value, there may be a stacking of different incentives built into the agreements, and something that needs to be taken into consideration, particularly given the regulatory environment, which we'll discuss in a minute. I'm going to actually ask our in-house panelists, maybe I'll ask Kelly and Robin, since they do a lot of contracting in this space, what they're seeing happening in the marketplace, and if they have any thoughts that they want to add with regard to trends of 2015.
Thanks, Andrea. I think in terms of what I'm seeing a lot more shift in payment towards quality and a shift in putting clinical compensation more at risk in order to pay our employed physicians for those quality and goal-aligned metrics. The qualities are starting to get more robust, so it's not something that it's a give me necessarily out of the gate, but rather it's going to require some effort on the part of that physician to really move the needle toward a metric that perhaps a goal that the board of directors is looking at into the future. In terms of the stacking, what I would say is, there's a presumption that the physician compensation surveys report compensation that's all in. So all of these elements of compensation are already built into the survey data. And so certainly it's very important to look at each individual component of the physician compensation, but also the whole. I think Jamie talked about this earlier, but for instance, in clinical research compensation, sometimes we see physicians who perform E&M services in connection with a clinical trial. Well, we can probably, they may not be dropping a bill for that because the sponsor of the trial is reimbursing us for that E&M service, but we may be able to count the work performed by that physician by looking at the RVUs that would be credited for that E&M service. And then there's also the other side of research, and that's the time and effort in preparing protocols for review and attending IRB meetings. So all of those services we're looking at in detail. What are the duties to be performed? We're asking our evaluators to analyze the compensation that should be assigned to those duties, and then also the overall compensation altogether.
The big trends we're seeing is also a big focus on at-risk compensation, which is increasing, where physicians' compensation can be reduced if they're not meeting certain metrics annually. The quality, also, like what she said, is becoming more a larger figure, a higher percentage of what their total compensation is, with the metrics being more difficult to achieve each year. We've focused more on updating these metrics and bringing in some clinical people to really develop a strong set of metrics. One of the big focus is making sure that they're not just any type of gimme. You need to really focus on making sure that they're a stretch for the practices and the physicians in order to obtain any type of compensation for that. As far as the stacked compensation, we also do an all-in approach with evaluations, and we look at what are they receiving as a base salary? Is there any type of production? Is there any quality incentive? Were there any types of transition payments that are being forgiven over the year? Is there a medical directorship? Is there on-call? And look at the total value against the independent surveys and see where it falls. You can always take out, when evaluating later, when you're looking at justifications for employment, anything submitted via time logs like medical directorship and hours, but for the main approach when evaluating total compensation, the trend that we see is definitely all in comparing that number against independent valuations. And just as one point, the at-risk compensation, we're seeing that in both the employed and the professional services that we're doing for our, that I'm seeing. So I'll turn it back over to Andrea.
Thank you, Robin. I'm going to try and pick up the pace a little because we are running a little bit short on time. Can we have slide 25, please? So the next portion of our presentation was a look at factors contributing to the 2015 transaction trends, or what we think are the factors contributing to the 2015 transaction trends. One is that we are in year 5 of implementation of the Patient Protection and Affordable Care Act, or PPACA, and there's this continuing shift from volume-based to value-based payments with focus on the triple aim. I have a variety of acronyms here on this slide: the Hospital and Patient Value-Based Purchasing Program, PQRS, or Physician and Quality Reporting System, Medicare Shared Savings Program, or MSSP, Readmissions Reduction Program, RRP, Bundled Payment Care Initiative, BPCI. The world is full of acronyms now, but all of those acronyms stand for programs that are attempting to drive value and shift the emphasis in healthcare from value to volume of services. And with that change, I think we are seeing, as Kelly mentioned, as Robin mentioned, changes in the way that physicians are compensated and the way that other providers are being compensated by hospitals, and the way hospitals are being compensated, and I think that's part of what's driving the change. We're also seeing changes in funding and reimbursement for primary care as a result of the Patient Protection and Affordable Care Act, changes in demand for certain types of healthcare services. There is now in place a sunshine law requiring reporting of payments from manufacturers, and I think that that is changed in some respects the way that hospitals contract for services that are needed, for example, in connection with clinical trials, and the way that they contract with manufacturers for things like research funding. There's more attention to how much is being paid and for what, with the idea that there would potentially be some disclosure to the public of what those amounts are, and high dollar amounts might create some scrutiny. As Jamie mentioned, there's evolution of the Bundled Payment Care Initiative, and also coming up in 2016, mandatory bundled payments for hip and knee replacements, and that's affecting some relationships among providers and also creating some interesting questions about how providers should be paid. Next slide, please. In 2015, we had passage of MACRA, which created the permanent SGR fix, but also contained provisions for value-based payment going forward, or sort of an accelerated timeline for value-based payment through the alternative payment system. APMS and MIPS are going to affect reimbursement going forward. That's coming up sooner rather than later. There were changes to the gain sharing CMP to open the door to more value-based hospital physician arrangements, and changes to hospital reimbursements, including GME payments and funding for community health centers, and also the National Health Service Corps. So some interesting changes from MACRA. There's another program that we did recently that provides some more detail about those changes, but just wanted to kind of give you some highlights here so that you had an idea of sort of what's going on in the marketplace. Next slide, please. As a backdrop for all of this, there is a federal timeline formally announced for achievement of alternative payment models. The HHS has set a goal of tying 30% of traditional or fee-for-service Medicare payments to quality or value through alternative payment models by the end of 2016, and tying 50% of payments to these models by the end of 2018. They've also set a goal of tying 85% of all traditional Medicare payments to quality and value by 2016 and 90% by 2018. Those may be ambitious timelines, but the fact that they're out there in the public, I think, has made people take notice, and I think also the private payers are taking notice and kind of following the lead of the Medicare program, and putting some emphasis behind causing the shift to value-based payment to occur more quickly rather than more slowly. And I think that that will start to influence some things in 2016, even more so than in 2015. This announcement was at the beginning of 2015, and we saw some changes in emphasis in 2015. I think they'll continue in 2016. Next slide, please. There were a number of developments that occurred at the end of 2015 that may affect transactional activity in 2016. I'm going to turn things over to Adria, and well, actually first to Kelly, who's going to talk a little bit about the 2016 physician fee schedule, and then Adria is going to give a few remarks on bundled payments and site-neutral payment and the new proposed 340B regulations, and maybe mention a little bit about the Yates memo, and then I want to make sure that we get to our 7 tips in fairly short order. Next slide, please.
Thanks, Andrea. I'll be very quick. Next slide. There we go. 2 changes that occurred in the NPFS final rule for 2016 with respect to Stark. There is now flexibility in order to retain and recruit NPPs into a physician practice. There are very specific requirements that must be satisfied in order for a hospital, a rural health clinic, or an SQHC to meet that exception. However, we think especially for rural areas that will provide some great flexibility to retain primary care services in an area where there may otherwise be a shortage. And then the second new exception is a physician timeshare arrangement exception. And we've been looking for this for a long time, I think. The interesting part of this new exception is that it's not exactly characterized as a lease, but rather a licensure agreement. And CMS said in the commentary to the final regulations that the license agreement could not grant rights to the entire world in the way that a lease agreement would. From a fair market value perspective, you know, I think folks, at least I've seen in my practice, that folks have relied on occasion the 2000 OIG advisory alert that set forth a formula for determining block timeshare lease arrangements. And so it'll be very interesting to see what happens in 2016 and beyond and how we're going to value those license agreements going forward. There were some clarifications, too, to the Stark regulation, a couple that provide us a lot of flexibility as a provider. The signature requirement, for instance, we now have 90 days to obtain signatures, and we can hold over agreements on an indefinite basis. A couple of cautions, though, on the holdover arrangement. While the holdover exception allows us to hold over under the same terms and conditions as that existing agreement, CMS makes very clear in its commentary that the holdover must be at fair market value at the time it's held over. So, in other words, if we continue to hold over, and at the time we hold over, the fair market value, for instance, of a lease agreement has changed, we may end up in a situation where we're out of compliance with Stark. Next slide, please. Adria, I think this is yours.
Oh, on the reimbursement changes? Sorry, I thought the main thing the physician fee schedule did was also establish different reimbursement models, and it added a few things: chronic care management codes. For the first time, there's reimbursement for advanced care planning codes, and end of life consultations. A couple new procedures for telehealth lists. So these were, I think are welcome revisions in the physician fee schedule. And then also what was mentioned earlier on, there were substantial changes in some of the quality reporting initiatives, like the physician quality reporting schedule and the value-based payment modifiers and the HR incentive programs that are starting to move in the directions of more value-based payments. Next slide. So two things which came very late in 2015 but are going to have significant impact on transactions for 2016 and are already having significant impact. The first one was the real bombshell that fell on November 2nd when Obama signed the Bipartisan Budget Act of 2015. There was a provision in that act that was designed to obtain site neutrality for off-campus hospital outpatient sites. And basically, the compromise in the budget bill contained a provision that excluded from Medicare payments. So Medicare payment to a hospital outpatient site typically would reflect the cost incurred by the facility, and it would be reimbursed at a higher level if it was on the hospital's license and operated a hospital outpatient department, meeting all the right criteria for provider-based. But the budget bill basically provided that if for off-campus hospital outpatient departments that were if they were in existence and already billing, then they're permanently grandfathered. But for any new ones, so that ones that come into effect after November 2nd, 2015, they may be reimbursed on a provider basis until January 1st, 2017, so basically just for the next year. But then they default to having to be billed under an alternate payment structure as an ASC or physician office schedule, basically, and that's the site neutrality. There are probably going to be some technical changes that are expected, I believe, around December 18th. I know there's a lot of activity around this right now. It's possible there may be some change. One thing that we're anticipating is that there may be some additional grandfathering for transactions that were well underway on November 2nd. And I would note and the CBO estimated that this will save Medicare $9.3 billion over the next 10 years. But it does create some problems. Obviously, it affects the ability of the hospitals to develop or integrate lower-cost ambulatory facilities off campus. It really affected a number of pending transactions, hospital systems that had invested significant dollars, and transactions that would really benefit the communities that the hospitals serve. It also oddly will result in a bifurcated system because of these grandfathered hospital outpatient departments that are going to be able to bill at this higher rate. I think it's forcing hospitals to look at alternative models, so it is going to affect some of those transaction structures we were talking about earlier. I would note in looking at this that these payment changes only apply to Medicare. We're anticipating that private payers may follow suit at some point, but as of right now, that's not the case. And so in doing an economic analysis on a transaction, the delta may actually not be so significant. So it really is, it should not necessarily be a deal killer. It's just something that really merits careful consideration in thinking about and evaluating the economic aspects of a transaction. Next slide, please. The other thing that is really going to come into play in 2016, at the end of the summer, the Department of Health and Human Services issued proposed omnibus guidance on the 340B program, which, for those of you who aren't familiar with it, the 340B drug pricing program is a program that offers certain participating providers, known as covered entities, the ability to receive significantly discounted drugs for their outpatients who meet program requirements. And the discounts are required to be offered by drug manufacturers. And some of the typical covered entities that benefit from this program are DSH hospitals, critical access hospitals, sole community hospitals, cancer hospitals, federal qualified health centers, and other recipients of Health and Human Services grants. And a lot of transactions are often structured to take advantage and really maximize the 340B savings to these entities. It's been under scrutiny for a long time, and the guidance that was issued at the end of the summer would propose some significant changes potentially to the 340B program. It's expected that the final guidance, I think they're currently saying it will come out in September 2016. Often those dates get pushed back, but that's what we're looking at now. And some of the proposed changes that are being considered. And so they went through a comment period, and now they're developing the final regs, having collected numerous comments on their proposed guidance. And some of the proposed changes would include the definition of patient, and where the physician that orders or refers for an infusion or for the drug needs to be employed by or under contract with the hospital. And the covered entity would need to be able to bill for the professional services provided to an individual for that individual to qualify as a patient. And on a side note, in some states where there's restrictions on entities that can employ physicians, that one prong of the patient definition could be particularly problematic. And then, excuse me, there's a new requirement that only patients whose services are billed as outpatient services to payers would be eligible for 340B. And then it also clarifies for Medicaid managed care patients and trying to avoid duplicative discounts. And there's also integrity provisions covering audits and record retention requirements and the like. Next slide.
Thanks, Adria, for that overview. So I just want to go quickly through some slides related to the current regulatory environment, because I think they're going to provide some interesting context for our tips, which I know we've been promising up to this point. There are a number of OIG advisory opinions and fraud alerts that were specific to hospital arrangements in 2015. The most significant, perhaps, is a June 2015 fraud alert regarding physician payments. It didn't say anything earth-shattering, but did underscore that OIG and the government in general are kind of looking at that as a potential, or those payments as a potential area of fraud and abuse. And in particular, I think was meant to send a message to physicians that they are being scrutinized. And Robin is going to say a few words about that in a minute. Next slide, please. There was definitely heightened altered enforcement and compliance landscape in 2015. We saw an increase in Healthcare False Claims Act litigation. I think we've been seeing that for several years. There were 700 plus qui tam actions filed in each fiscal year, 2013 and 2014, 638 filed in 2015. A number of those settled or had significant developments in 2015. There were $16.5 billion in federal healthcare fraud recoveries since 2009. $1.9 billion of that amount was in 2015. One thing that I think became apparent in 2015, and something that we started to see in 2014, is that unlikely qui tam relators are the new trend. Folks who are somehow involved in a transaction, work with or for a hospital, and become disgruntled or upset and decide that they're going to be qui tam relators. We'll talk a little bit about that in a minute. We've seen exponentially increasing legal fees and settlement amounts. We have here a list of some settlements, starting with Bradford, which made big news when it settled a few years ago, and it was $2.75 million settlement. And then we have Adventist Health System in September settling for $118 million. That figure includes $115 million to the federal government, and then some money that was going to the state government. There have been attention getting court rulings and settlements throughout 2015, and those involve claims against not only the hospitals but also their employees and physicians. Next slide, please. We have some other items on this slide that relate to the altered enforcement in compliance landscape. Affirmative repayment obligations for Stark violations, which has come up in at least one case recently, one qui tam case recently. The Stark self-disclosure protocol, which provides availability of an avenue to reduce potential liability. It seems that folks that go into the SVP and report their Stark violations do a little bit better than those whose Stark violations come out in a qui tam suit. We already mentioned the Sunshine Law, and one thing I do think we should mention is the Yates memo, and I'm going to have Adria say something really quick about that. But this is a DOJ policy statement indicating that DOJ will seek individual accountability in issues of corporate wrongdoing. So Adria, do you want to say something really quick about that, being mindful of time?
Sure. It was a memo that came out as a result of a working group of senior attorneys from various governmental departments and U.S. attorneys, with the goal really to recover additional money, but also to try and place accountability and deter corporate misconduct. And so the guidance was applicable to civil corporate transactions, and looking at how they can better pursue individuals in some of these actions or alleged improprieties. And so I think that has potential implication and raised a lot of eyebrows among in the healthcare world when we're looking at potential increased individual liability.
And definitely increased risk for state law claims as well. They're being bundled in with the federal claims, and a lot of the qui tam lawsuits and Medicaid compliance issues are becoming more important as Medicaid becomes a more important funding source with Medicaid expansion and the Affordable Care Act. Next slide, please. So there's a little bit on this slide about the physician compensation fraud alert. In the interest of time, I'm going to just sort of refer you to that, and we're going to skip to the next slide.
The heightened and altered enforcement in the compliance landscape, there's been a huge increase for healthcare enforcement. The budget has just been going up exponentially, and we believe that the increase reflects the support for the trend of high enforcement efforts. Another reason for the increased enforcement is the return of investment for the money spent enforcing healthcare fraud, which is about $8 for every dollar spent on fraud and abuse control. The Appropriations Committee expects the healthcare fraud and abuse control to generate more than $5.4 billion. One of the reasons for such a high return on investment is the high settlements and penalties. You'll see when the cases are described, there's just some huge multi-million-dollar settlements. Another trend is holding physicians personally liable for improper contracts, like the fraud alert showed for the medical directorships and the Columbus Regional Healthcare, where a physician was personally liable for over $400,000. Another thing to note is the dramatic increase in whistleblowers. Whistleblowers are coming from all different people these days, from physicians to high-level management. In 2015, there were over 600 already. There are over 700 in 2000 and 2014, and and partially that's because of the large amount of money that whistleblowers can get. Some whistleblowers are receiving upwards of $12 million at this point. And that's from different people in the community. If you could go to the next slide. One thing you'll notice when we walk through the cases is that most of the arrangements that are being investigated involve some type of employment arrangement with physicians. When developing an employment relationship, it's vital to have a compliance program to mitigate that risk. When examining the employment relationships, the recent cases and trends show that you need to evaluate the contract from a multi-layered perspective. There's an increased focus on commercial reasonableness in addition to just the fair market value being assessed. One thing to do is obtain an independent valuator opinion, which can be helpful to determine whether the arrangement's within the norm for the specialty in the market. Next slide.
So on the next few slides, we have some summaries of some selected qui tam actions that involved hospital compensation, mostly to physicians. I'm going to refer you to the facts and not go through each of these. I think in the interest of time, it doesn't necessarily make sense to do so, but I think we'll point out a few things in general about the cases. One are the nature of the qui tam relators. You'll notice that a lot of them are either insiders or physicians who were involved in negotiations, and somehow those negotiations went bad. In each case, there are allegations of violation of the Stark Law and or anti-kickback statute through compensation that was not fair market value, was not commercially reasonable, and or took into account volume or value of referrals. Can we go to slide 46, please? So to just kind of summarize here, I'll let you kind of read through the narratives on those cases on your own time. But the issues, as I mentioned, that were raised: fair market value benchmarks, accuracy of information underlying the valuations, that's a big one. And we'll talk a little bit about that in the tips. Practice losses seem to be a focus and raise a red flag. Commercial reasonableness, relationship of compensation to volume and value of referrals, tracking of referrals and contribution margins. In at least one case, there was an allegation that tracking was going on in secret logs, and that became some evidence that was used against the facility or attempted to be used against the facility. It was allegations only. It settled without a finding of liability. Emails and statements as trial evidence, and limits to advice of counsel defense and attorney-client privilege doctrine. So with that, let's get to our tips for 2016. Number one is remember the triple aim. Next slide, please. So the triple aim is improve the patient experience, quality and patient satisfaction included, improve the health of the population, and reduce the per capita cost of care. These tenets are really the new combustion engine for healthcare and new drivers of value. We're certainly seeing that in the valuation perspective, and I think that's influencing the types of transactions and the nature of the transactions that are being entered by hospitals. Next slide, please. Number two, productivity is important, but so are quality and value. I'm going to turn this over to one of my co-presenters to kind of talk a little bit about this.
Thanks, Andrea. We've mentioned throughout that the payers are expecting good quality. Our patients deserve good quality. So our hospitals and our provider entities are focusing more on quality. This slide does show an evolution of physician compensation for physicians based on productivity and the move from productivity to quality, and certainly not to undermine productivity. Some of the cases that were in our earlier slide deck suggested that, for instance, quality didn't match up with the compensation and or collections from the practice didn't cover the physician compensation, though. So we certainly don't want to disregard productivity. However, we've seen that the government is shifting its focus on quality. In addition, there have been False Claims Act cases alleging worthless services and the level of care necessary, medically unnecessary services. For instance, in the Adventist case, part of the claim was that there was consistent upcoding of E&M services and medically unnecessary services. So continuing to monitor quality and to provide good quality of care is very important to the government, as demonstrated by its policies. Next slide, please.
So number three, don't go it alone.
And all
I'll talk about that one.
This is Adria. And really, there's still a lot of the models, although we talked about the site neutrality and 340B and some of the things that are going to have implications for a transaction that you might have considered doing in 2015. There are alternative models out there, and I think kind of given a little bit of reflection and consideration, there are options out there. We're seeing a lot of activity kind of across the continuum, post-acute, subacute affiliations, and some of the clinical affiliations and the co-management models that Jamie talked about. And kind of the collaborative approach may be one of the keys to success as you tee up for the future. The note of caution on this tip, on this particular tip, is to, especially given all the changes in the market and the enforcement, it's very important to work with not just advisors, but informed advisors. Don't just hire any evaluator. Hire somebody with healthcare experience, and make sure that there's full information. And if you do look through the summaries of the cases, you'll note in particular some of the larger judgments, including the Twomey Health System, which finally settled for $72.4 million after a court judgment of 200 plus. There were opinions there, but the court and jury found that there was evidence that there had actually been opinion shopping and that not full information had been provided, and so that the valuations that were legal opinions that were relied on were discounted and ultimately arriving at a decision. So it is important to really work with people who know about this and really provide all the information. Next slide.
Number 4, assume sunshine everywhere and be prepared for when the clouds come.
There's the healthcare activities, as we talked about earlier, is increasingly scrutinized right now and in the spotlight with the increase in qui tam suits and the increase in the focus from the OIG and the Department of Justice. It's so important to make sure that your program is in line and the compensation packages that you are approving and implementing are appropriate and within the guidelines in order to avoid any issues. Part of that is key to that is having appropriate documentation and a process that can demonstrate fair market value and commercial reasonableness and show that it's being considered and show the factors that you use to come to your judgments that show that. It's vital to have a strong compliance program that reviews the compensation, and the documentation which should show your reason and your rationale behind entering into any contract is vital, especially if any compensation package were to come into question. Some important things to make sure that you're documenting throughout the next year is your fair market value assessments, your performance for practices, and another thing would be written explanations of the community needs and your recruitment efforts, especially if their compensation package falls a little bit higher on the scale. There needs to be some significant documentation in order to justify why you've entered into these contracts. Next slide.
Number 5, remember that when someone loses, someone wins, or we are all losers. Vivian, you want to take that one?
Yeah, thanks, Andrea. So again, to tie into what we were talking about in number 4, the Department of Justice has latched upon this idea, at least in the last Florida settlements, that if you're tolerating as a hospital any professional losses in a practice or by a physician, that must be evidence of an intent to purchase referrals, which, as anybody in-house knows, losses are going to happen. And so along with the documentation advice, we would advise that you document the why. There are a lot of very legitimate reasons why you're going to have practice losses, but as you continue to employ a physician or maintain a practice that has losses, you need to document that you need them for either for call, or these are highly specialized services like pediatric subspecialties who see a lot of Medicaid and that's why they have losses, or that you have to maintain this level of expertise to maintain your trauma center status, et cetera, or this is a new position. So document the why when you have losses. Also, we've been advised that the 10% rule is a good rule of thumb, that unless you are within 10% of paying, the productivity matches what the payment level is or what you're going to pay for an acquisition, more than 10% than they earned last year, you need to document the why. So if you're paying a lot different than they have produced, again, explain why, and that's the best protection that we could offer right now. Next slide.
Number 6, be reasonable.
And to that end, we've talked about the qui tam relators that have been involved in many of these cases. In some instances, those qui tam relators brought complaints forward to their health system administrators, or they were competitors within the community that brought forth complaints because they believed that they were treated unfairly or were unhappy that they didn't get similar offers. So with that in mind, of course, the first tip is acrimonious relationships or negotiations may breed relators. And so we always want to take complaints seriously, investigate them thoroughly, and communicate openly with our staff who are involved in physician compensation relationships. And then, of course, we also want to treat these transactions with reasonableness, and commercial reasonableness is required in 8 of the Stark Law exceptions. So how can we demonstrate, for instance, commercial reasonableness in a transaction where a physician may not cover their costs from professional fees? We may look at the payer mix of a hospital, the amount of uncompensated care, other clinical and non-clinical services provided by the physician. We've talked about that today, teaching, research, perhaps this particular physician is doing novel research in that community, the need for the specialty in the community, the fact that Medicare and Medicaid pays below cost in some instances. And we want to document those very well, which is a consistent theme with our 7 tips for 2016. Document, document, document. Next slide, please.
Number 7, remember that the devil is in the details.
Part of this is just making sure that there is complete and accurate information when you are assessing fair market value and commercial reasonableness, and when you make decisions for your compliance program, as well as when you use an outside valuator, and collect all the relevant information for them and make sure that it's as accurate as possible. The key to obtaining fair market value assessments in your hospital for your hospital compliance is that the data has to be the correct type of data. The type of data that we generally like to collect are the compensation structure and proposed rates, physician-relevant prior compensation, productivity patient visits, professional collections, overhead, pro forma for the practice, and all relevant opinions and history. And this will keep you out of trouble more if you make sure that all of your information and all the relevant information is accurate and has the correct data to be looking at in assessing your commercial reasonableness and fair market value. And then I will turn this over to Andrea to wrap up.
I wanted to know if actually any of our panelists had anything to add to this number 7, the lucky 7, devil is in the details tip. Adria, did you have some thoughts you wanted to add on this one?
Well, I think that was a very nice summary, and being mindful of time, I don't know that I'll add anything. I think that the themes throughout this have been to be mindful of the regulatory environment in which you work, and to be sensitive to the fair market value concerns and the commercial reasonableness concerns, and to document, make careful judgments, and to document what you're doing. But that being said, there's a lot of opportunity out there still, and a lot of options for 2016, and we wish everybody the best in taking advantage of those opportunities.
All right. Well, I thank all of our panelists for participating, and I thank you all for joining us today. If you have any questions about anything that we've talked about today and you didn't get a chance to ask those questions, feel free to submit them through the chat box now, and we'll try and follow up with you individually after the program. Thanks again, and I hope everyone has a great week and enjoys the holidays.